Aloha, everyone. Thank you so much for joining us at our mini medical school. I'm Dr. Buenconsejo-Lum. I'm the Associate Dean for Academic Affairs here at JABSOM, and happy to provide a little bit of an update for you related to COVID-19 in Hawaii. So today we're going to talk about just a recap about this virus that has been with us for more than 18 months. But there's always new and changing information, so I'll provide you with an overview, speak a little bit about moderate to severe COVID disease, and talk about long COVID, because certainly now we have unfortunately had a lot of experience with COVID in the United States and in Hawaii. So I'll speak a little bit about what that is. And then I'll speak about the COVID-19 vaccines, plans for booster shots, and some other things, because there's always a lot of ongoing information and studies related to the COVID vaccines. And then we'll just end with a quick reminder about how we can stay healthy together. Okay, so the variants, right? We've all been living with a little bit of fear about what are these variants, and the alpha and the delta and all these letters. Thank goodness the World Health Organization actually named them alpha and delta. But the idea is that this type of virus, just like the flu virus and some others, they pretty commonly cause these little mutations. And remember I said that their entire purpose is to stay alive, right? They can't live by themselves, they need a host, but their entire purpose is to stay alive. And so sometimes you have mutations in the spike protein, in this case, and that is what has made this much more easily spread. And so what we are most concerned with the Delta variant is because we know that the changes in the mutation actually cause the virus to be very sticky and stick to your inside of your nose cells. And so think of it as if the regular virus was like Elmer's glue to your nose, then, the Delta variant is kind of like super glue. It's really, really sticky. It's very hard for the body to attack it. And then because it's sticky, it makes copies of itself at about 1,000 times more than the original wild type virus did. And so that's why it spreads 100% more quickly than the original virus. In fact, it's probably closer to 2.5 times more infectious than the original virus. It's not known if it causes more severe COVID-19 disease, but at the end of August, there was some data showing that, in fact, it might. And this is based on data looking at hospitalized patients of the same age compared to when they were hospitalized, so younger people primarily, right? Being hospitalized, the rate of younger people being hospitalized, say in, April, May, even December of last year, compared to the rate of younger people being hospitalized now in July and August. And it's almost 2 times the rate. And so, again, a couple of small studies, but it's certainly looking like it may be the case. And in fact, Delta does, so it's not only is it more infectious, but it also may cause more severe disease. Now, the other mutation, going back up to the middle, is that some mutations can cause the antibodies to not be as effective. And so the way that the immune system works, think of it as the army of the body, right? And so we have a foreign invader into our bodies, and our cells are trained to recognize that and remember it. So the idea with the vaccine is that we're injecting just a teeny little amount of the mRNA, teaching our bodies how to make just the proteins, so not the actual virus, but just the proteins. And then when we get if we get the real virus, then our body is going to be primed to respond. And there's 2 ways to respond. The antibodies that our bodies make, but then there's also, it activates these memory cells. And those memory cells really do remember for many, many, many years. And so even if the immediate, response from the antibodies may not be that great, because maybe it's been 8 to 9 months after your vaccine, your memory cells are going to kick in and are going to have a pretty good response, especially for severe disease, right? And so that's all good. That's how the immune system is supposed to work. That's how vaccines work. And all of those things like measles, mumps, and rubella, chickenpox, smallpox, right? We don't hear about smallpox anymore because it was essentially eradicated because, those of us that were alive in the very late 1950s and early 60s, we all have the scar because we all got it, and I'm included in that group. I still have the scar from my smallpox vaccine, right? And so now we don't even know, we hardly see it. And the hope is, right, can there be some vaccine for this family of viruses, not just this particular virus or this particular variant, but for this family of viruses, so that maybe one day, we can forget about this one too. I don't know, but that's how the vaccines work. So the challenge is that some of these variants, it shows that your antibody treatments are maybe not as effective. They're still effective in preventing severe disease and hospitalization. And I'll show some of that data a little bit later. But, is anything going to be 100% that you're not going to get infected at all? No, absolutely not. And I think early on in the pandemic, that was the messaging, right? Oh, we hope we get this vaccine and we're all going to be perfectly protected. And it wasn't exactly, it was very, very high, but the whole point of vaccines, just like the flu shot, just like the pneumonia shot that I hope you all got, it's really to keep you out of the hospital, right? It's to prevent the most severe disease. And so, so that remains to be seen. But that's why it's actually very important for as many people to get vaccinated as possible, because the sooner we reach herd immunity, again, I'll have a slide on what that looks like, but the sooner that we reach herd immunity, the less likely it's going to be that these viruses can last long enough in the body to mutate. Right now, when we have a substantial part of the population that's not fully vaccinated, the virus can go in, have a huge party in our nose and in our body, and nothing's going to be unchecked. I mean, it's going to be unchecked, right? We don't have immunity to it. And so then it's going to replicate, and every time that the virus replicates and makes thousands and millions of copies of itself, there's always that chance of that little mutation. And so that's why it's really important to have good immunity, because then you shut that down pretty quickly. And we see that people who, even people who have had the vaccine but have these breakthrough infections, they're actually able to shut down the virus pretty well in about 3 to 5 days and no longer infectious. And then that way we're also not going to give the virus a chance to mutate. Okay, so that's a little bit about variants and why we worry about them. Okay, this graph at the bottom right, I know you can't see it really well, but these are our curves for our different counties. And I just wanted to point out that at one point, Hawaii, so the orange number at the bottom, the 52.6, that is a terrible number for us. Okay, so there's basically 53 cases for every 100,000 people in Hawaii as of August 30th, that have, the virus. And on Hawaii Island, it's actually 66 per 100,000. Honolulu County is 51. Kauai is 42. Maui is 49. Okay, so in May, our numbers were down to like 7 per 100,000. And so in May and June, Hawaii was actually among the top 5 best places, right? Which is why we all thought, oh, okay, great, right? It's safe, we could do more stuff, and travel guys can come in. Well, you know what? The issue is not the visitors as much. It's us going to Vegas or like wherever, and then not paying attention because we're all good, right? Oh, you're vaccinated, hoo-hoo, we're immune. And we come back and we bring it and we infect everybody, right? And so that's what happened. And so that's how we went from the top 5 to the bottom 10. All right, and we are doing our best to try to get that number low again and to flatten the curve and to prevent our hospitalizations from going any higher than 460 hospitalizations. This is just COVID. that is already overloading the system. The max capacity really is about 500 hospital COVID patients, and we already in the end of August have needed federal assistance to bring in nurses and respiratory therapists and whatnot, because the staffing is really a challenge. And so you may think, oh, well, we have lots of hospital beds, right? I look at the Department of Health reports or the HIMA reports. It's like, gosh, we have 2,000 hospital beds. So if we have 400, what's the big deal? The big deal is that the rest of the hospital beds are filled with people, our family members, who have really, really bad asthma, who have heart failure, who are having heart attacks or having strokes, who have terrible infections, who have poorly controlled diabetes, and or people who are, having traumatic injuries, right? Car accidents, spinal injuries, whatever it is. And so the hospitals are full already, and then we have this COVID surge, and so it gets to be very, very, very difficult to make sure that we have enough care for whoever needs it at the time when they need it, right? We don't want to be like some of these horror stories in the mainland, where people are waiting and waiting and waiting, and maybe they have a really bad outcome, right? So that's the whole idea with transmissions and why all these different shutdowns. Okay, and actually, I take that back. So this 52.6 was August 26th, and a week and 3 days later, it went up to 60.9. So why is this so bad? This virus, well, it gets into your lung, but it also goes deep. It gets into your nose. It also goes really deep into your lungs, and it causes a pretty bad pneumonia and really a big need for oxygen. And so, as a sign that our health systems are being overwhelmed, at the end of August, it became more widely known in the newspapers that we are facing an oxygen shortage here on Oahu. And so, that's why the different restrictions have gone in place, because we really don't want to run out of oxygen. This is a bad pneumonia, and if you can see the X-ray, normally if you look at the chest X-ray at the bottom right, it should be nice and black. Right? Black means there's air. White means there's stuff that's all, gunked up in the nooks and crannies of your lungs. And when you have all of this pneumonia and inflammation and fluid and debris and cells and mucus, well, you know what? Air can't really go through. Oxygen can't exchange. And that's what this is. And so this virus has a very, very strong reaction in the lungs, but the body also makes this huge inflammatory response. And so in the most sick people, they also have, heart attacks, or at least infection of their hearts that can cause a weakening. They will often have kidney problems, if not actual kidney failure. Sometimes they have to go on a heart-lung bypass machine. That's the ECMO. It's pretty significant. So this, again, is super, super, super bad virus. And people who do need hospitalization also tend to stay a lot longer in the hospital, which is another reason why the hospital beds are running out, because people it's not like a regular pneumonia where most people are out of the hospital within 5 to 7 days. People who are hospitalized with severe COVID disease are often there for 3 to 6 weeks. And so again, that makes it a really big problem for the hospital beds. COVID-19, we know, tends to be worse in the elderly and those with multiple chronic conditions. The older you are, the higher chance you are of getting sick enough and dying. And certainly for those with severe heart disease or poorly controlled diabetes are also at risk for severe disease and death. And of those that had severe disease, about half of them went on to actually get organ failure. And so, prevention is really critical. Now, at the end of August, there is something called Regeneron CoV or Regen-CoV, which is a monoclonal antibody, and it's indicated for people. So you have to test positive, but also be very high risk for hospitalization or death. And so again, at the end of August, the health systems was ramping up up. So because there aren't enough places in the hospitals to give this infusion, because there aren't enough hospital beds. I mean, there aren't even enough ER beds, right? And so the community health centers and there's other discussions about setting up places. So where if I was, 65 and I had poorly controlled diabetes, I'm at kind of high risk, for getting a pretty severe disease and hospitalization. And so, I'm going to contact my doctor, and they're going to then try to make arrangements for me to get this monoclonal antibody treatment. And so all of this was starting to be put in place at the end of August. Okay, so what about post-COVID or long COVID? Some of these conditions, so I already mentioned that if you're sick enough to be in the hospital with COVID, in general, your length of stay in the hospitals tend to be 3 to 6 weeks. Just being in the hospital that long, and certainly being in the intensive care unit for that long, is going to cause all kinds of problems. You're going to be more weak. You're going to need rehabilitation. You're going to have trouble breathing. You're going to need your pneumonia is so severe. You're going to be on oxygen for quite a long time, et cetera. And then just again being in the intensive care unit. So that's the stuff on the bottom right. This post-intensive care syndrome. Well, long COVID actually happens in people not in the ICU. So it certainly is more likely to happen if you are very sick in the hospital. But it can also happen in people who have never been hospitalized. And so the most unfortunately publicized example here in Hawaii was Senator Kalani English. And so he never ended up in the hospital, but he had long COVID such that he could not focus on work, and he had to resign from his state Senate position because he wasn't able to do the duties because of the brain effects. And so we do see difficulty thinking or concentrating is a big prominent feature, in fact. And so that has implications for being able to work or go to school and be successful in school. What's not on this list, but what we certainly see is a worsening or we have mood changes at the bottom, but we see a lot more anxiety and depression. Certainly the difficulty breathing and the tiredness and fatigue that can last forever. Okay, so lots of questions about the vaccine, and certainly even though the Pfizer vaccine has been given full licensure for use in persons 16 years old and above, we know that there's still a lot of questions about the vaccine. And we know that in part for some people, just the questions around the science of it are making them a little bit more hesitant to receive the vaccines. So the reality and the facts are that work on this vaccine, because we had the original SARS a long time ago, work on that vaccine began over 15 years ago. And the technology for the mRNA vaccines has also been worked on for about 20 years. So we had a lot of good stuff going already in terms of science. And then because China made the gene of this virus available to everybody, in, December, then the whole world all the scientists could work on sequencing it and figuring out exactly how to fine-tune that vaccine, right? And so then they could do that because, again, we have amazing technology nowadays. And then the other thing was once they got something that looked pretty promising, they were able to combine the phase 1 and phase 2 trials. And phase 1 trials are really, those are the ones in humans. And so you see on the diagram at the bottom, the first thing on the left is the genetic sequence, right? And then they quickly looked and did, studies in animals, and that's pretty much how all vaccines start, just to, make sure safety and all those kinds of things. But then the phase 1, 2, 3, that refers to trials in humans. And so many of the vaccine manufacturers, and there's over 40 throughout the world, were phase 1 or phase 1 and 2 combined or phase 2 and 3 combined. And then there was also just a ton of money poured in. And so, but the safety standards, in fact, are just as high, if not higher, than any vaccine that has ever been made in the history of mankind. And that is not an exaggeration by any stretch of the imagination. And I have another slide on that. And so these vaccines are really, really safe. The CDC and the FDA have been criticized by some, why are you taking so long? Well, they're taking long because they want to make sure that it's really, really safe. right? They're also criticized by others that say, you guys did it too fast. And, but the safety is the primary concern, safety and efficacy, and making sure that these vaccines can be rolled out equitably. That's the primary concern for both the CDC and the FDA. So while it seems like light speed, and that was the Operation Warp Speed, in retrospect, probably shouldn't have used that term because it really made people like, oh my God, you bypassed all these things. So they weren't bypassed, but there's lots and lots of close monitoring that will continue to go on. And for Pfizer, really for any vaccine that will get full licensure, there'll be at least 2 years, but really 5 years of follow-up, because there's just a lot of questions to be, to be asked. And so there's really several different types of vaccines. The viral vector vaccines is a weakened virus. That's the Janssen or Johnson & Johnson, and AstraZeneca, which is more in Europe or other parts of the world. In the U.S., the Johnson vaccine has only gotten about 14 million doses compared to 92 million of Pfizer and 65 million of Moderna as of August 26th. And so the question that comes up is, well, I got the Johnson & Johnson, what about the booster for me, or what about this? So, the Johnson & Johnson vaccine rolled out a little bit later, and there was a pause, and there's just not as much data, 14 million compared to, even 65 million or 150 million combined. That's like 10 times the amount of mRNA vaccines compared to the adenovirus vector vaccine. And so in terms of safety data and monitoring all these things, we just have a lot more data on the mRNA vaccines. And the data is accumulating, and there's some very good data coming out on Johnson & Johnson, but because of the timing, we just don't have quite enough yet. And so that's why, at least at the end of August, there's no information yet about the booster or an additional dose for the Johnson & Johnson. All right. So anyway, so there's these different types of vaccines. The bottom line is there's no live virus in any of these. Even the viral vector vaccine, it's not even there's no live anything in there, and it is impossible for any of these existing vaccines to work into your own DNA and cause you to turn into a zombie. It is actually scientifically impossible. Okay, so the mRNA vaccines are the Pfizer and the Moderna. Again, 150 million doses given so far, tons and tons of study safety data. Again, you cannot get infected, very similar safety profile. When you hear vaccine efficacy, those are done, what they do is they look at in the clinical trials, they look at the people who got the vaccine and the people who didn't, the placebo group, and then they compare the number who tested positive by a nasal swab, the number of people that tested positive 7 days after they received their second dose. And that's how those initial vaccine efficacy numbers were generated. And so early, pre-Delta, the vaccine efficacy for the mRNA vaccines were in the 94 to 95%. Now that there is Delta all over, then that number is a little bit less, and it varies from place to place, whether it's Israel or the Mayo Clinic or other places. But what makes it hard to decide, is it that the vaccine is less effective, is because all these fully vaccinated people also started traveling and doing stuff without their mask, right? And so is it hard? Is it really that the vaccine is less effective? Or did this vaccinated population or these other populations, did they just, go and have fun and have a little bit increased risk, right? So some of that is some of the data that is going to be continued to be teased out and looked at by the CDC. By the time you view this on October 2nd, we'll have a little bit more information. But we do know from some real world studies that, again, Delta is just not great. But even with the Delta variant, it is still more than 80% effective in preventing severe COVID-19. And so that is really the true efficacy that we're looking at. And we see this in our hospital data. 90% of people hospitalized with COVID are unvaccinated. And these numbers are true across the country, here in Hawaii and across the country. And about 10% of them are the breakthrough, but they tend to be mild, and almost none of them are in the intensive care unit, right? There's a few, maybe older, immunocompromised, so again, maybe didn't mount such a great immune response. Okay, some of those folks, unfortunately, are getting sicker. And we've had a very few who have passed away who were fully vaccinated. It's usually those folks. They were much older or just sick. Their body didn't make that good of a response. But if you're a younger person, and you don't have any immunocompromising conditions, the chances are high that maybe if you get sick, you're not going to end up in the hospital. And if you do end up in the hospital, it is much less likely that you're going to end up in the intensive care unit compared to an unvaccinated person. Okay, so the mRNA, all the vaccines still work to prevent severe COVID disease, hospitalizations, and death. And that is the message to remember and to tell all your friends who may still be questioning the vaccines. Okay, there's still lots and lots of questions, though, that, there will always be questions, right? We're inquisitive people, and we should always continue to ask good questions. And so how long will the vaccine last? Well, now we know that with the vaccine, again, just looking at pure infection, so not looking at preventing hospitalization and death, but looking at pure infection, and based on some studies with antibodies, it looks like, the antibodies last about 6 to 8 months, but again, probably longer in people who have kind of, intact immune systems. And that's because of those memory cells. So there will be more information about that. And that in part is what the CDC is going to consider, for boosters, or is considering for boosters, and any future booster considerations. And even with Pfizer, even though it's gotten full approval, there will be these ongoing studies again for 2 to 5 years. Another question, will the vaccination prevent asymptomatic infection? Well, initially pre-Delta, the data was looking pretty good. Now with Delta, yeah, maybe, but actually there is some data. And so the way that we try to phrase it is, if you are fully vaccinated compared to an unvaccinated person, that unvaccinated person is still much more likely to catch the Delta variant than a vaccinated person. Okay, at least 2 times more likely, but probably more, 4 times. However, once any fully or unvaccinated gets the Delta, we can spread it, right? And so, the vaccine, again, is helpful in preventing the Delta infection, but it's not 100%. Okay. But there's, again, a lot of ongoing studies. Will this reduce the transmission? Again, I kind of talked about that. The other question early on was, do you need 2 doses, or is 1 enough? And so now we know, especially because of Delta, you really do need the 2 doses for the mRNA vaccines and the AstraZeneca, Oxford, Sinovac, Sinopharm, the ones that are in China and India. Those are all 2-dose vaccine regimens. And you definitely do need that. And the Janssen has some actually very promising data to prevent hospitalizations and death after the 1 dose, after like 6 to 8 months. But there's also tons of ongoing studies. These clinical trials were also designed to answer this question. And so those studies about what is the optimal timing for a booster, and even the mix and match studies, if I got 2 Pfizers and maybe I get a Moderna later, is that going to help me? Is that going to be better than getting a 3rd Pfizer? Or all of those mix and match ones actually are ongoing. And so, I think we'll all have more information by January. But again, some of these studies are being done now, and just enrolling people in clinical trials now. And then what we do know now, compared to, say, even 4 months ago, is that the vaccines are incredibly safe in children aged 12 to 15. And in fact, right, they were approved for, and this is just the Pfizer, for children 12 to 15. And the full licensure for Pfizer is for 16 and above, but the 12 to 15 is still under that emergency use authorization. And that is why we're all trying to have, lots of vaccine clinics at the schools, whether it's, the school complex or other schools, because it is really, really safe. Pregnant women, very safe. So yes, early on, the clinical trials originally did not include pregnant women. I mean, to enroll in a clinical trial early on, you had to have a negative pregnancy test. But certainly women got pregnant, and there were some in the clinical trials that actually carried their pregnancy all the way to term and had babies, and really no evidence for any problems with fertility, no evidence for any kind of birth defects or anything like that. And what we do know is that when pregnant women get COVID, they are much more likely to get sick, super sick, intensive care unit, dying, or sick enough that their babies have to be born early, and then the baby might have, kind of long-lasting problems because they're born too prematurely. And so the risk of getting a maybe minor, unknown, theoretical complication from the vaccine compared to the real risk of dying from getting COVID, it's like this, right? And so we really need everybody who's pregnant, we need all their physicians to please get the evidence, talk to people. They have to get vaccinated, because we should never have to do, CPR on a young, healthy, pregnant woman. And that is, in fact, what we're starting to see in Hawaii in August. Okay. Now, the 5 to 11 years old, we're all waiting for this. Those of us have little kids or little grandkids in school, we're just waiting. And the evidence looks really good, but it probably won't be until maybe October or November that we'll have a kind of approval. So in the meantime, keep your children and your grandchildren masked, pack their hand sanitizer, right? Just really good common sense hygiene stuff. All right. There are a few people that shouldn't get the vaccine, but it's very, very rare. And so this is where the medical exemptions come in. And so if you had a previous allergic reaction to any previous mRNA vaccine or for the Johnson & Johnson, okay, then yeah, you shouldn't. Now, having said this and everything on this page, there actually have been people, healthcare providers mostly, who, despite having that reaction, that history, or despite having the first anaphylactic, nobody died. And their risk of getting really sick and dying from COVID is very real. And so many of them actually have chosen, under the right conditions and with the right monitoring, to get that second dose. And you know what? The great majority of them all did fine. So again, to date, there have been no deaths. Anaphylaxis, we've had lots of data now, so from December 2021 until August, we have 8 months of data, and it's anaphylaxis 5 per million. Very, very, very rare. And so a true medical exemption is very rare for getting a vaccine. Okay, anaphylaxis means, though, kind of immediate, within 15 minutes, wheezing, trouble breathing, dizzy, blood pressure, etc. All the rest are precautions, and so that's why if you have, like me, I have an allergy to an antibiotic, and so I got monitored for 30 minutes. Right? Some people might have a shrimp allergy or a seafood allergy, so you get monitored for 30 minutes, and they all do just fine. And I have another thing, but basically looking at all of the data for Pfizer, about 11% of people have a reaction that is classified as severe. And like, oh, severe. Well, when you see the list, it's like, for the most part, it's really not that severe, right? Sore arm, redness, maybe a few that need to go to the hospital because the arm pain was too bad, or, pretty significant muscle aches. But most of those go away within 72 hours, So again, these vaccines are super, super safe. There's worry about Guillain-Barre syndrome. With the mRNA vaccines, there are no cases to date. And this to date means as of August 26th. No cases of anybody with Guillain-Barre following the mRNA vaccines. With the Janssen vaccine, there was one case and one also in the placebo group. So it doesn't look like Guillain-Barre or having a history of that is actually a contraindication. There's a lot of people running around with Bell's palsy, right? And so there have been people in either the clinical trials or after the clinical trials, there have been reports of Bell's palsy, but they happen pretty equally if you got vaccinated versus versus not vaccinated. Or Bell's palsy is actually kind of common, well, not super common, but it's common enough with COVID. because Bell's palsy can be triggered by the virus, any virus, right? And so again, right now, all those safety studies are continuing, but so far, Bell's palsy doesn't seem to be associated with any vaccine at this moment. Okay, so here, herd immunity, right? You hear about this, and you remember we're like, oh, okay, we need 70%, right? Yeah, okay, so no, 70% is not enough because we have the Delta variant. And so what the top one is, okay, so the blue people are you're not immunized, but you're still healthy, okay? The yellow people is that you're immunized and healthy. And the red people is you're not immunized and you're sick and you're contagious, okay? So in the top bar, where you see a lot of blue people on the left, that's essentially where no one is immunized. Right? You have two red people, so two people that are contagious, and they're going to spread through the whole population. And look, almost everybody is red on the arrow. Okay, so that's how it was, in December and January. All the way really through August, or really for all of 2020, right? We didn't have vaccine for all of 2020, pretty much. And so the top bar is how that was. And so our surges and all those deaths, New York City, nursing homes, all of that. Okay. So the middle bar is kind of where we are. And some states are worse off. And some states are a little bit better off, but Hawaii, we're in the little bit better off, but we're not at 85%, fully immunized, right? So, but what the middle bar is that you get some of the population gets immunized, okay? So that's the yellow people, but you still have contagious people running around unvaccinated, and so you can still see that you're going to have a lot of people that turn red, right? That become sick and contagious, and that is exactly what we're seeing with this latest surge in Hawaii in this August, September, timeframe. Okay. Whereas if the bottom is where we want to go. And so when you have an agent that is as infectious as the Delta, so with a R naught of around 5 or 6 or 7, meaning that one person can spread it to 6 to 8 people, okay, then you need to get closer to 85% of your population fully vaccinated. So not just initiating one dose, but actually getting both doses of if whatever the recommendation is. So in the case of mRNA vaccines, it's 2 doses. So you need 85% of people to get both doses. And then 2 weeks later, that means you're fully immunized. So that's what we want to get to, is this bottom. So what that means is that when most of the population gets immunized and you still have infectious people, you're not going to have nearly as much infectious people because everybody else is immunized, right? So that's what herd immunity is, and that's what we want to get to, and that's why we continue to push super, super, super hard to get all the unvaccinated people who are eligible to get them vaccinated. Okay, and so this is another graph, but I thought the pictures were easier to understand. But this is actually from Singapore, and this is pretty much, so this is where the 80 to 85% number comes from. It's actually more like 85. But this just shows you that if you don't have a vaccine, so for SMM is safe management measures. Here in the United States, it's all these preventive measures, right? So the mask, the physical distancing, but you can see that even if you have these measures, the masks, okay, you need to get 80% or more of the population vaccinated to kind of keep the infection rate really low. Okay, so anyway, so our target is probably going to be closer to 85% of the population. Okay, so just a quick word on Pfizer. This was, fully licensed towards the end of April. And then on August 30th, the CDC Advisory Committee on Immunization Practices met and had unanimous approval to support full licensure for Pfizer in 16 years old and above. And the data presented, looked at data from the time the Pfizer vaccine was introduced, which is December 2020, all the way through July. Now, we know that the Delta variant started to take hold more in July, right? And so that's why there's ongoing studies to really look at how Pfizer is stacking up against the Delta. But even with that data so far, it shows that it did prevent a COVID infection with symptoms, about 90% of the time. And it lasted for at least 4 months. And certainly there's other studies done on other vaccines, 6 months or so. Now, the Israeli studies is what got everyone kind of worried. Oh, we need a booster, our immunity is not, good, not lasting, et cetera, et cetera. And so, there certainly are some of these other studies showing that it's less efficacious against the Delta. But again, the point is the third bullet, that the vaccines are still very, very protective against hospitalization and death. And there were numerous studies, all between 95 to 100% effective in preventing hospitalization and death. But again, there's going to be a lot of data collection ongoing. Here it is, 11% of people with Pfizer, this is 92 million doses, with these kind of pain, swelling, a rare number, small numbers needing to go to the hospital or the ER, and the great majority of side effects go away within 72 hours. Almost all the rest of them go away within a week. Anaphylaxis is about 5 cases for every million shots given, and that has been steady since the beginning. And then myopericardis tends to, you see it more with the mRNA vaccines. It's very rare. It tends to happen in younger men, or under age 30. But it's mild. They present with chest pain and often, and then it's really 1 to 2 days of hospitalization, normal cardiac function, normal on follow-up, no problems with activities. There is a rare person that gets more sick from the myocarditis after the vaccine, but it's extremely rare. Whereas getting true myocarditis from the virus, 6 to 34 times risk of moderate to severe myocarditis with the actual infection. And these are the people, kids, young people, young adult males with prolonged hospitalizations, heart failure, needing to go on the heart and lung bypass machines and in the intensive care unit. So again, we worry, we hear all this stuff about the vaccine, but the bottom line is that the vaccines are really safe, and the risk of getting super sick and dying, even in young people, where it's like this, right? And so we need to not have people die unnecessarily. Okay, these are a bunch of different graphs, and I just put the top one just to show that on the left side, those blue bars are all the prevented hospitalizations and the prevented ICU compared to the very small number of cases of myocarditis from the vaccines. Okay, so that's just a graphical way to show what I just said, that the benefits of the vaccines far outweigh the risk of getting myocarditis from the Pfizer or the mRNA vaccines. If you're a numbers person, then the bottom graph table is what it is. And so you've got, again, this is in the 16 to 29-year-old range. And you can see that maybe, a little bit higher in the 16 to 24-year-olds, but you're preventing a big number of cases and actually preventing thousands of hospitalizations and preventing hundreds of ICU admissions. And so, and then again, the myocarditis with the vaccine is super mild. Okay, and then this one is, to me, this graph on the bottom right is the most easy for my brain to understand. And so this is looking over the next year. So it's trying to project out with the Delta variant and with the different levels of vaccination in the population, how many hospitalizations are we going to prevent, right, by giving a vaccine versus the red line, which is the number of myocarditis from the vaccine. And the reason that the red line doesn't go up is because pretty much the myocarditis from the vaccine is seen within the first 21 days, and it doesn't change. Whereas we know that the more Delta variant is running around and the higher number of unvaccinated people in the community, the higher your hospitalization rates are going to go up. So the vaccines are safe. They're very safe, please. Okay, so the booster question. The dots just either at the top line is like 100% vaccine efficacy. And so you may or may not be able to see it well, but the gray is pre-Delta. And the colored dots are now in the era of the Delta variant. It's kind of crazy that we have to classify things pre-Delta and with Delta, but again, super smart virus. So before Delta happened, again, vaccines almost 100% effective, right, in preventing hospitalization and death. But now we know that based on data and with the Delta variant, that the blue line, the blue dot, is the estimate for people over 65. If you've gotten the mRNA vaccine, so either Pfizer or Moderna, it's a little bit, it's not 100%, but it's still 80%. which is still pretty darn good, okay? And then the yellow is looking at Pfizer, Moderna, or the Janssen vaccine. And the estimate protection against hospitalization for people 75 years or older, it's still around 80%. So again, it's still pretty good, right? But there are studies now showing that, yeah, maybe in long-term care facility residents, a little bit decreased efficacy, or, we're starting to see more infections. Certainly, the vaccine, is we need to really continue to look at the data for older groups and healthcare personnel. And so by the time you see this, I'm obviously recording it early, but by the time that you view this, the CDC actually should have weighed in on the booster question. And based on the available evidence, the booster will likely be recommended for residents of long-term care facilities, for healthcare providers, and then for adults, either over, probably starting with age 75 and older, because those were the ones that got the vaccine first, right? So if you think way back to January, the push was for 75 and above. So here in Hawaii, push for 75 and above. But before then, it was healthcare providers were the 1A. The 1B was the folks in the long-term care facilities, and then the next group, the 1C, was the kupuna 75 and above, right? So those guys got their vaccines earlier, and based on the available data and, antibodies waning maybe, and this whole Delta variant craziness, they will likely be the first to be recommended for boosters, and so you may be eligible, but certainly during the question and answer session, we have to answer more questions. Now, what about this additional dose in the moderate to severe immunocompromised? So in the middle of August 13th, in fact, is when the recommendation was that immunocompromised people could get additional doses. So some people say it's a booster. It's not. Additional doses are really that third dose for people who are thought not to have had a good immune response with the first two doses, because they're cancer patients with chemotherapy. They are maybe have psoriasis or other autoimmune disease, and they're on injectable medicines to try to help control their autoimmune disease. Maybe they had a big accident. They didn't have a spleen, or maybe they were born without a spleen, or maybe they have terrible asthma or something, and they're on prednisone 20 milligrams more a day. Those guys are classified as moderate to severe immunocompromised. People who are in hemodialysis are also kind of in that moderate range. And so here in Hawaii in August, it started becoming eligible for these groups of people, right? And so the key is to, and then the other caveat, though, is if you are a cancer patient on chemotherapy, we are asking you to please talk to your oncologist first to determine the best timing for you to get that additional dose, because it does matter. For everybody else, you can self-attest, you can sign up on the CVS website, whatever, and get your other dose. But for people on chemotherapy, depending on where you are in your chemotherapy cycle, there is a better time to get the vaccine. And so we're urging all of patients on active chemotherapy to speak to your physician. Okay, and the last slide, thank you very much for bearing with us, but it's really, again, I should add C for common sense, but it's really, you want to avoid closed spaces with poor ventilation. You want to avoid crowds, and you definitely want to wear a mask if you're going to be in a crowd. And you really want to try to, at least now while the Delta variant is raging, you really want to minimize contact with people outside of your usual social bubble, right? And so, but always, wear a mask, practice social distancing as best as you can, wash your hands, carry your hand sanitizer with you. And again, the physical distancing and the mask are the most effective ways, aside from the vaccine, to prevent you from getting severe COVID infection. So thank you very much. Stay safe, and I'm happy to answer any questions.